informal on one of these things. So thanks very much for coming along to this one. Anyway, this one is all about belonging. And I think it follows on quite neatly, actually, in some ways, from what I heard Christina saying at the end of the plenary session just now. And I wondered at first what we meant by belonging, actually, for this, but it turns out it's there to cover a wide range of things, including diversity, employee voice, inclusive leadership, a proposed common register, and professionalisation through common training standards. So I suppose if you take a step back from that, what it's all about is what more can we do, should we do, to ensure that, you know, the wonderful people who work in social care feel valued, feel listened to, really get the support that they need to do the good job that they want to do. And, you know, it's an interesting day to be doing it, isn't it, on the day the white paper's being produced. And it's great that we've got speakers in this session who really span the health and the care system, which is terrific. And of course, a number of them have feet in both camps, as I'm sure they'll explain. But if it's okay with you, I think we're going to start. I ought to say that I was supposed to be co-chairing this with my friend and colleague, Nadra Ahmed, who's the chair of the National Care Association. But actually, the truth is we were both conflicted with two meetings and we did a toss-up, basically, and she's gone to one and I've come to this one. So she sends her apologies. Hi, I can see Victor's joined us, which is terrific. Hi, Victor. We're just kicking off in a gentle, informal sort of way. So yeah, Nadra might make it towards the end, but she's not here at the moment, so I'm afraid you're landing with me. Which is bad luck about that. Also, at the end of this session, I gather we will be automatically transferred into the plenary, so you don't have to do anything. Basically, it'll all happen automatically. And what we're going to do is to just, you know, hear a little bit from our excellent, fantastic speakers, sort of 5 or 6 minutes or so. And then it's open to a, you know, really nice informal debate, and everyone's very welcome to contribute, and the more the merrier, I think. So, Victor, you've been here about 2 seconds. Do you feel okay about starting, or would you rather sort of catch your breath? Would you like David to start instead?
I haven't been anywhere. I was going to nip on my bike, but I didn't have time, so I'm here.
Okay, very welcome.
I'm ready to crack on. It's great, actually. I listened to Andrew, and Paul. It was like, this is your life, isn't it? Sort of people. Which is kind of good and bad at the same time, because it is a sort of deja vu moment, isn't it? You know, the number of times that we've talked about social care and the need for it to be addressed. And you get to a point, actually, where the question isn't what needs to be done, but why hasn't it been done? You know, because the answer to that question might help us think about, you know, what intervention do we need to put in place to get this thing moving, because it's profoundly worrying. And the fact that the pandemic has it's just shone. I mean, I think that Alistair Burt's phrase, you know, it has shone a merciless light on our lack of attention to the whole system. And I have to say, I find it odd that we're calling for a social care people plan. You know, it's like, well, shouldn't we have a social care, health and social care plan? Given that the future of integration is going to be about integration of workforce design as much as anything else, just seems profoundly weird to have two separate plans. It makes no sense to me. But I suppose, you know, plans are plans. But I'm a great believer in the saying that I think it was Mike Tyson, the boxer, who said everybody's got a plan until they get the first punch. And we've had a few plans in this. And speaking as the chair of the NHS Confederation, we have been very much involved in the fight, I suppose, for recognition, or in the Health for Care Coalition, which is 15 organisations that we've joined forces. And it is highly unusual for a sector like health, or like an organisation like NHS, to sort of champion the cause of another, what people might consider to be another sector. But it is abundantly clear that without social care, the whole thing starts to fail. I mean, it is failing because of our lack of attention to social care. And I think it's profoundly shocking that even the disproportionate deaths in social care, just the risks that social care frontline workers have taken during the pandemic, I still feel has not been recognised enough. And the disproportionate impact of that has generally fallen on black and minority ethnic groups. Now, it is expected and it's boringly repetitive for the 6-foot black guy with a name like Adebowale to bang on about race, and I really don't want to. But I'll just say that it's fundamentally obvious that we have not been leading, older people all the time, have we? I think I can say that with a high degree of confidence, given the disproportionate impact of COVID. And that needs to stop. It doesn't really matter what colour the leadership is. You get paid for leading older people all the time, and if you're not, then you get what's happening now, which is disproportionate impact on those people at the sharp end of the inverse scale. So, and a lot of those are in social care and work in social care, and they also happen to be the same people that the government wants to level up because they can't afford to live anywhere else but to live in those places that are more likely to be impacted by the inequities of that inverse care loss. So I just think we are in a place where I would argue the health and social care system is drinking in the last chance saloon, and I think the brilliance of the health and social care workforce in dragging this country through the worst public health crisis in living memory, pretty much, needs to be rewarded by due care and attention to the future, and that future is set out in some way by what we're calling the reforms. They're not really reforms. We've been doing a lot of the things almost surreptitiously since the 2012 Act was enacted, because we knew it wouldn't work. So all we're doing really is embedding those things in practice for the future. What's missing, and we need to get right, we just need to get right, is the social care piece. And we need to, if the government isn't going to do it in a timely fashion, I think we need to strain every sinew of our authority. And there's people on this panel who have far more authority than me, to its maximum, to ensure that social care force get the following things. First of all, they get leadership that is actually inclusive and leads all the people all the time. Secondly, they get professional support, certification, and permission to work at the maximum of their skills. I do not ever want to hear anyone call social care workers low-skilled. My mother doesn't get a low-skilled social care worker; it gets a very blooming high-skilled. And I think that needs to be recognised, and that needs to be registered, and it needs to be trained and understood, because that's the only way we're going to attract young people into a very necessary industry. We need to sort out the pay. I mean, I just think it's unacceptable, really. I think Alistair said it right. We've just discovered who the most important people are in this country, and we need to sort them out in terms of pay. And we also need to just ensure that when we talk about social care, and it is just a blinding glimpse of the obvious, we just need to understand that it's not just about the elderly. And when we talk about the elderly, it's not about the elderly that look like Miss Marple. Social care is about social care. It's about the 1.5 million people with learning disabilities. It's about those people with severe enduring mental health problems. It's about those people with physical and mental and emotional needs that are underplayed. And it's about, the 10% of us, 10, 15% of us that are going to get ill. No matter how fit we are now, something's going to happen to some of us such that we're going to need support. Let's take the comprehensive view of social care, and let's not let our politicians of any party reduce it to a convenient political minimum. If we can do those things within our authority, I think we can move the needle far enough to force the reluctant politicians, and there's a plague on all the houses on this. I'm a crossbench peer, as you know, so I take some pleasure sometimes in slagging them all off. But I think, we need to pull them forward. And in order to do that, we need to use the maximum of our authority to do so. I think I'll end there. I've got a hard stop for something else at 4 o'clock, so I might not be in the main plenary when we pull back. But, I just thought it was important to register the Confed's support for this and understanding that we've really got to get it right this time. Thank you very much.
Great. Thank you, Victor. That's a really great provocation to start us off. And I think Sam has joined us, so welcome, Sam. Your our fourth speaker, just letting you know, okay? So just relax and kind of get yourself into the session, as it were. So after Victor, we're going to have Sir David Behan. And I don't know which of your hats you're wearing today, David. It might be Health Education England Chair, is it? But you might want to just say a little bit about your interest in this sphere, as it were. And you're on mute, mate. Needless to say.
It's about the 5th time today. Thanks. So I don't know, do we have to strut our pedigree to be here? So I've social worker, director of social services, DG in the Department of Health, where I've written 2 white papers, 1 green paper, and I was the person that actually physically commissioned Andrew Doolnot to do the Doolnot report. So that's my background in this work. Currently, I'm chairing Health Education England, but I also chair HC1, which is one of the large care providers, residential care providers in the UK. Actually, they cover England, Wales and Scotland. Scotland, of course, have just announced their independent review by Derek Feely, which again begins to set the future. But I am here, Caroline, to your point on the invite was to me in my role as chair of HEE. So of the title for this workshop, mini summit, I've gone down the end of the title, which is a common register, professionalisation and common training standards. So I'm going to focus my comments there. After a lifetime in social care, my firm belief is that the best social care transforms people's lives, and it does that by delivering personalised care, which allows people to live independent and fulfilled lives. And I'm going to start and try and address my comments to not what the gaps and deficits are in the system, but what the assets are and what we might do. And staff, in my view, and the workforce is one of the assets, and they've demonstrated that through the pandemic. Their dedication, commitment, but also their courage and bravery has been quite outstanding in my view. But what I've heard them say over the past 12 months, I heard them say it before, though, was that they want to be valued, recognised and rewarded. So I'm going to look at valuing, recognising and rewarding, and my comments are going to be directed towards that end. I'm going to cover 4 areas: demography, demand, the sector itself, supply, what we've learned through the pandemic, and then some thoughts on workforce reform, that's social care workforce reform. And trying to do that in 5 minutes is a tough ask. I'm starting with demography quite deliberately. I take absolutely the point that social care covers the whole of the age range. But the drive at the present time for social care demand is through the population of older people, and the numbers of us aged over 65, that includes me these days, is set to increase from 10.5 million in 2020 to 14.1 million in 2035. That's a 34% increase in older people. And the good news is we are living longer, but the not so good news is we're not living healthier, longer lives. And it's that unhealthy aspect of life expectancy which is driving demand, particularly for older people. And what it's driving is the requirement to deliver services to people with complex comorbid conditions, dementia, frailty, cardiovascular related illnesses. And that's driving demand both for support for people in their own homes, different schemes of housing support, as well as for residential care. And I think the particular challenges are around, for residential care, are around dementia care and end-of-life care. I'm going to come back to that because it's important just to reflect on what are the needs this system is here to meet, and how are they going to go about meeting them, and what are the skills that are required to meet those needs. If I had longer, I'd want to talk about the advances of science and technology over the next 20 years and how they're going to, because I think the demand side needs to be shaped, not just in terms of population demand, but also some of the advances in science and technology. A little bit now about the sector and just some dimensions, and I'm grateful, I don't know whether there's anybody from Skills for Care on this call, but we talked about the absence of data. I think Skills for Care have almost carried out a single organisational mission to improve the quality of workforce data, and I think the recent state of care reports have been quite outstanding. 18,000 organisations, 34,000 establishments, 95% of all provision in the independent sector. 1.5 million workers, 500,000 of those in domiciliary care. But what we also know is we've got turnover of 30% plus. For care workers, it's 38%. For nurses, it's 41% turnover. 82% of the workforce is female, 27% aged over 55, and the average age is 44. And 21% are from Black, Asian and minority ethnic backgrounds generally, and that figure is 66% in London. And when we come to how many have been have a qualification, that's me at the end of my 5 minutes, have a qualification, 50% have a qualification, 45% have a qualification to level, of care workers up to level 2, and 79% of senior care workers up to level 2. But what is level 2? Level 2 is largely about mandatory training. It's a bit more than that. And I think we need to have more ambition in terms of the offer that we're making. And my question is about whether that training has kept pace with the demographic changes in the number of people with dementia at the end of life, which comes to Victor's point about the skill which is required to provide either any care for people who are receiving care at the present time. What did the pandemic told us? Well, viruses find the weak spot in any system, and I think what this virus has done is find the weak spot in the health and care system, and it's exposed the fragility of the care sector. But I think the upside of that is there's now a greater awareness and recognition of the role of care staff, both by politicians, but also by members of the public. I was fascinated by the Ipsos Mori Sentiment Veracity survey, which I don't know whether you're familiar with this, but Ipsos Mori asked who were the most trusted people in public life, and doctors and nurses always come out on top at about 95%. But care workers were in here for the first year I can recall, and they were in at 76%. They're about 9th on the list, higher than the police and higher than priests. And advertising execs were at the bottom on 13% and politicians on 15%. So I think there's something really interesting in that reflection of both the investment and recognition and trust that's invested in care staff, which needs to be built on. So what about workforce reform? Well, we've touched on it, 12 white papers, green papers, consultation documents, 5 independent reviews in the past 20 years. And Victor was saying, let's look at why those things haven't been implemented. I'm happy to have that conversation, but I think it's for another time. My own belief is that we'd only get reform when we have a majority government at the beginning of the term and with a Prime Minister who's committed to reform. And, you know, if it wasn't for the pandemic, perhaps we would have had those 3 things lined up in that way. But let's see where we go. Let's see where we go. There's a number of events coming up this year, a budget, and I'm with Andrew Dilnott. The spending review is a key event here, and that's what I think we need to be working towards. But what would I do in respect to the workforce? Well, it's interesting. I wrote this on Monday afternoon, and some of the things have already been reflected at the top of this particular session. I'm coming back now to these headings, Caroline, about value, recognise and reward. So what would I do? And I just look, and I don't know, Matthew, whether you're going to reflect on these in your presentation, but if we look at the healthcare workforce, it's both valued and recognised. interesting point about how far it's rewarded, but it's valued and recognised in a different way to the social care workforce. And I've tried to unpick why is that. And I think one of the reasons is that in healthcare, there is a substantial investment in the workforce and their education and training. And what I think we need to do in social care is make a substantial investment in the education and training of the workforce, which goes beyond the levels that we've currently got. It goes beyond the care certificate and the mandatory training, and does begin to provide the input that is going to be required as we look to the future to provide care for people with complex comorbid conditions. I would also introduce a register for the social care workforce, fascinated in the chat around the Welsh experience, but I don't want a register so people can be excluded from it. I want a register so you can be admitted to it on the achievement of qualifications. And I think that will drive education and training reform, but it will also give the public the confidence of the skills that have been achieved and the education that has been achieved by the workforce. And as I say, I think that curriculum needs to go beyond the statutory minimum. There is an argument for linking this to the structures of healthcare assistants and the nursing workforce. I'm not arguing it should be on the nursing register, but I think people need to be able to see themselves developing a career where they can actually progress through various roles over the years, not just, I don't mean hierarchically, although that would be an important part of the development of a role, but they can actually see themselves committing to the workforce, because it's essential we do something around these, I think, incredibly difficult turnover figures that we've got. And as I say, I would make education and training a requirement for registration. And in that way, we would both recognise and value care staff and the role that they play. That would begin to professionalise them and begin to develop a career structure where people could commit to a career in health and social care. And finally, I would also want to see changes to the rate paid for care. And I think we've got a greater read across between health and social care careers, career structures and qualification structures. Then I think we can begin to think of a more sensible way of actually rewarding care staff, which is not just about national minimums, but is actually a true equivalence in the way that services are brought together. I do recognise that would cost money, and I'm very clear and support Andrew's contribution at the top of this conference about we need to ensure that the state contribution to the risk pool recognises the role that staff play as well. My maxim, I could have begun this presentation by saying, if we look after the staff, they'll look after the people that use services. And I think what we've done over the years is we've focused quite properly on the needs and voice of people who use services, and perhaps we've not given enough time and attention to the voice of people delivering services. But if we can get that right, then I strongly believe that we'll get the delivery of the quality that we need for the people who require access to services. So invest in the staff, and they will invest and deliver in the quality of care to people. Thank you.
Great, thanks ever so much, David. You did slightly exceed your time, but I didn't stop you because it was so good. And I think it's really useful and great for everybody to hear you, because as you made clear at the beginning, you have just the most wonderful experience to bring to this really important topic. We're going to pass over to Matthew now, Matthew Winn, who occupies a really, really pivotal position in NHS England of relevance to this topic. Matthew, it's great to have you here. Thank you for taking the time.
Thanks, Caroline. Delighted to be here. And So yeah, to those I haven't met, Matthew Winn, I have two professional roles in life. One is the Director of Community Health in NHS England, which also covers things like continuing healthcare, better care funds, and hospital discharge, all of which you will immediately see have a major interface with social care in terms of their effectiveness. And I'm also a chief exec of a community healthcare NHS organisation in the East of England. So juggle those responsibilities. I didn't want to, Caroline, repeat what everybody has said already on those big macro, really important issues about pay structure, the importance of the credibility of the social care world. And so I'm not going to touch on those, not because I don't think they're important, colleagues, is because other people have, and I knew they would, talk about much more eloquently already. So there's no point me saying it as well. I guess I wanted to just take it from a bit of a healthcare kind of lens point. And even though David and I share a heritage that both of us were social workers in the past and have moved over into the healthcare world, I have as Caroline said, a national role. And I'm also a great believer in that we need to design some of these solutions into our systems to make sure they happen. They don't happen by osmosis, and even if we had the right pay for the social workforce and we had the right remuneration, we had the right money going into local government, we would still have problems in the interface between health and social care, and we must design that better together. And I'll talk about that in a second. In reality, the NHS and social care are absolutely interconnected in their effectiveness on some really key areas. Not everywhere, but I'd say things like children's with long-term needs, adults and older people with frailty and long-term conditions, learning disabilities sphere, people living during mental health. These are the areas where we absolutely collide. There are lots of areas in healthcare where they don't collide, and we need to let people just get on and do those things separately. And Caroline, if we were to blow Caroline's trumpet for a moment, because she won't, was a long proponent, as manifested itself in the long-term plan, of making sure that we talked about care delivery in a different way. And I think another unfortunate aspects of the pandemic is that the issues that within the long-term plan, which were health and care orientated, whether that's anticipated care, which is about providing care in an integrated way, in a proactive way between health and care, whether it would be a 2-hour response service, so everybody in England were able to get care within 2 hours if they're in a crisis that didn't need to go to a hospital. Those things have been shunted back somewhat, and we need to, for this coming year, really bring them back up to the central focus of local areas being able to deliver those things. Interestingly enough, the third area in the long-term plan for older people was enhanced health in care homes. And I think that has really shown, slightly late in the day, I understand, but has shown actually that how the healthcare world working hand in glove with the care sector can make remarkable change in a very short amount of time. Not perfect, but actually where you get general practice, community healthcare, social care, and the social care profession doing this and agreeing how they work together, it's incredibly powerful. And that is despite all the systemic issues about pay. So I think those are the things where we need to design and collide the healthcare world into more and more interactions. I think thirdly, I would think about how we would take on areas where the health, and David talked about this, the health and care staff are wafer thin difference in terms of what we do. And I would, speaking with some level of knowledge in this aspect, the community health workforce, there is actually very little difference between what a great social care, senior social carer that Victor talked about and a healthcare assistant in our community nursing teams. They would not be doing much different. They will be paid differently. The healthcare world will probably be governed in a more active way by a registered professional potentially, but actually their tasks are very different. And it's therefore not surprising that Skills for Care, and I agree with David, Skills for Care do a fabulous job. 14% of social care staff each year go into healthcare. That's not unsurprising, because actually actually there is easy portability between the sectors. And so, you know, when we come to things like delegation of tasks, this should not be a dumping of tasks from the NHS into social care and thinking that's okay. This has to be designed as a shared endeavour to ensure that the right things are done wrapped around our most vulnerable populations, and the best person and the best supported person do that. And I think fourthly, therefore, the nature of designing this in is going to be really interesting. Do we, and on the day that the government's published their paper on integrated care systems, do we view that as a set of deck chair changes that just changes the architecture? Or do we actually say, no, this gives us a chance to talk about how health and care properly plan, not highfalutin strategic 10-year stuff from a health and wellbeing board, however important that is, but practical care delivery. And practical care delivery for me with health and social care staff would be, well, why are we not talking about the same footprint for care delivery for home care agencies, community nursing staff, general practice, so they operate as a multidisciplinary team, even though they have different terms and conditions, they're different agencies? Because I know from experience that if you design in people sharing the responsibility, sharing the information, agreeing what's going to happen, that is the way that you actually enact change. You might say that's a bit soft and fluffy, but it's the reality of integrated care, is that people are talking to each other, understanding which of the population they're worried about, and actually therefore doing something proactive to escalate, de-escalate, and make sure our intervention is right. So whilst I think, and obviously would say that there is lots of systemic macro work that needs to be done, I would just say, Caroline, as a last thought, that we can't just rely on that macro solutions, therefore thinking that will provide great care at the end of the day. We have to make sure that we are aligning strategically, practically, what we are doing on a week by week, day by day basis with our local workforce, and doing things so we align the really care delivery of health and social care where it makes sense, I think is something that we need to see more of. This year, we will be at last, because it was delayed by a year, publishing the enhanced health, the anticipatory care model. To debunk that, that essentially means know your population, understand its needs, start being proactive in the care management of that from a health and social care delivery. Absolutely what the long-term plan said, much easier to say than do. If that's not done with health and social care, domiciliary care at the heart of that, we will again fail and we'll miss the opportunity to really improve the outcomes for absolutely people that need to be supported in a very different way. So Caroline, as you would imagine, as you know me, I'm half glass full on these things. However, it is hard work to achieve that integrated alignment of people, but we have the ingredients. We need the leadership, including myself, to deliver that on the ground day in, day out to make sure that happens. And I'll pause there.
Thank you, Matthew. That's great. And now we're going to have Sam, who's from the Open University. And I think, Sam, you've got some slides.
Yeah, I have. I don't know if you're able to. Oh, here we go.
Yeah, it's all working. Brilliant.
Yeah, it's very academic, isn't it, to do slides? But I have to say, I've done these. These are far more professional than I could ever do, I can see. So thank you for inviting me. It's really good to be here. I'm Professor of Social Work at the Open University. I'm also Non-Exec Director on an Integrated Care Partnership Board, so kind of eat, live and breathe integration. Starting at the OU, I commissioned a survey at the OU to look at the impact of COVID on social care, and we did a quick survey after 8 or 9 months of the pandemic being in place to look at the impact on social care. So we did it around November, December, and there was 500 organisations that participated in the survey. And what we found, I'm going to just share those with you quickly, is we found some key messages that we all know and in fact have discussed today, but we also found 1 or 2 interesting things which I think go to the heart of where we might be going in social care, particularly with today's announcement. So generally, we found as an overview is that nearly half of employers are operating within or below the minimum skill level. So we know from that about 44% are operating within or below the minimum skill level, and that obviously that's quite concerning, around 44%, and that those skills, 67% of those that responded said that actually one of the big skills for the future in terms of recruitment is around adaptability to future challenges. So that actually what people were looking for in the sector was an ability to adapt to future challenges, which I think says something about how we've reacted to the pandemic. 42% went on to say that actually defined career pathways and progression opportunities remain the significant obstacles to recruitment and retention. I think we've already said that. And that actually the survey that we found, although this does slightly contradict some of the surveys that have happened in the private independent sector, is that the challenges were most pressing in the FSCC sector. And significantly, 54% feared that they would lose staff this year, and that they would lose staff following the pandemic, that once we come out of the pandemic, that we will begin to see actually staff move out of social care from the 500 people. So I think that's quite an interesting statistic. What we didn't know, because it was a bit of a snapshot survey, as to why that is. And I think that might be interesting to follow up a little bit more. I don't know if you could take me on to the next slide. Yeah. So what we then looked at is sector weaknesses, the effects of COVID, some post-pandemic concerns, and some future planning needs. So we know that 67% have changed their working practices as a result of COVID. And the same figure, 67% again, we're beginning to say that there is a skills gap. And the skills gap was in 4 key areas: leadership, digital innovation, technical abilities, and managerial. Some of those I think we would probably predict around leadership and management. In fact, we've said that earlier on in this mini summit. The digital bit, I think we would expect with digital innovations and use of technology. The bit that's slightly interesting is the technical support. So people are saying that there's a skills gap in technical, and by technical, the 500 organisations that we surveyed were basically giving examples of technical skills that border on health and social care skills. So a little bit of what Matthew and David were saying, actually. They did cite examples. There are examples, for example, like end-of-life care, medication regimes, a lot of skill gaps around the technical skill around cognitive and sensory difficulties that people experience, and definitely wanting to move into getting more knowledge and skills around technical aspects of the social care job. 58% constrained in their recruitment retention due to absence of established career structure. Post-pandemic, what we found is that there's 54% are worried about this skills gap and that it will continue post-pandemic. 51% were really worried that the staff turnover will increase post-pandemic. So as we move through the pandemic, there is still that emphasis that there will be a high turnover, and 56% are increasingly concerned about whether they will be able to retain their staff. So those 3 statistics in pink are directly related to the pandemic. So what we can see is that out of those that we surveyed, half, and more than half, remain very concerned about skills, turnover, recruitment and retention as we move through the pandemic. In terms of future planning, 54% were saying that there's a fear of shortages from Brexit, and people were saying that they felt that Brexit would have a direct impact on attracting people with the right skills and ensuring recruitment and retention stayed buoyant. And this interesting statistic, which I think relates to today's announcement, is that 38% wanted their focus to be on local recruitment. So what we found in the survey is that people actually wanted a localised delivery system and not a national system. And that 38% of our respondents were saying, let's actually recruit locally to make sure it's a localised service for local people in local communities. And again, that's quite an important statistic, I think, in terms of when we begin to think about what does integration look like. If I can have the next one, please. Yeah. And then we began to look at what were our recommendations, and also we've got some statistics on the left-hand side. With 59% saw the pandemic as a catalyst to different ways of working. Obviously, people were acknowledging that we need funding, as we have done. 39% were saying they want the more constructive private public VSCE relationships, and they wanted a focus to continue on that. What was really interesting about the recommendations was obviously some that we've already gone over, which is an established national career development progression framework, and they wanted that to be a national framework rather than a local framework, and that pay structures would be negotiated nationally. There was some discussion in our survey about whether that would be supported by professional association and or regulation and or registration, and what does that mean? Having worked in social care really for over 30 years, I think that's to be explored. So what would a professional association look like for social care? What would registration and regulation look like for social care? So we know with registration and regulation, it's about protection of the public, but how do we develop a system and organisation that supports the development of practice and the development of care delivery for social care workers? I think that was very much what was intended behind this piece of survey that we did and what people were looking for. A national plan for investment and recruitment and retention, and a targeted plan around those skills gap. Number 4, which I think was really interesting, goes back to this 38% statistic, was about promotion of social care for a new localised audience, and that actually a social care plan, whilst it might be national and it might be over a 10-year period, had to be about localised delivery. And that was a really strong theme in the response rates that we got. And obviously number 5 was about financial stability, which we've talked about. And number 6 is about having a 10-year social care plan. What's really interesting, I think, which wasn't a particular recommendation that we came out with, but 2 big issues, I think, for us to debate as people who've worked in social care is there's this notion around a social care plan. Now, often that's used in terms of either a vehicle for nationalism, and people have positive or negative views around that, or a national care service is something that reflects a national health service, and people again have positive and negative views on that. Or like the Scottish Independent Review come out and said that a national care service would be a commissioned national care service. So I think there's a bit of work to be done if we're moving down that area. What does a national care service look like, and what do we actually mean by that terminology? The second point for me that's a challenge for social care is about integration. So what do we mean by integration? Having worked at integration for over 30 years as a mental health social worker, actually, I've seen the challenges and also the gains that integration means. And what integration along the ICS and ICP systems is often around system integration as opposed to health and care delivery integration. And one of the bits that we've seen through the white paper today is the move from decentralisation to the proposal to move to a more centralised service. And for me, in social care and social work, that's something to be debated a little bit more fully. Do we want to integrate with the health service and move towards a centralised service when we know what works well in social care? And in fact, this survey supports that, is that actually a decentralised service that is localised, recruits from local populations, meets the needs of local populations, serves the needs of local populations, is quite fundamentally important to what social care is. And to that degree, it's slightly different from healthcare. The people that we work for and alongside with are those people who actually are your neighbours, are your aunts, uncles, brothers, who will be workers in the social care system, but in turn may then be in receipt of a social care system. So there's a closer relationship in social care that's a little bit distinct. So the move to put social care into a centralised system may change some of that. So for me, one of the things that I think we need to address as social care, people working in social care, is, well, what do we actually mean by that? And would that work for us around social care? And I'll leave it there. Thank you.
Great, thank you, Sam. So I've been the world's worst chair, and actually we've only got about 10 more minutes really in total for this session. But and people have been very patiently listening, but I'm not surprised because the speeches were all fantastic. It's your opportunity now to make some comments. If you haven't, you can do it in the chat, of course, if you like, but you're very welcome to speak as well. I think I saw Gavin waving his hand. Currently on mute, Gavin, actually.
Yeah, sorry. Yeah, I was physically waving rather than electronically waving. Look, fascinating contributions so far. Really interesting to hear people what people have got to say. I suppose I've got just a question, because there's been so many powerful contributions about the need for qualifications for professionalisation. I should have said, by the way, I'm from Unison, and I'm the Senior National Officer for Social Care. Lots of great contributions around qualifications, the need for training, a lot of stuff around placing a structure around the workforce in order to drive up standards, which I think is exactly right. But when I think about that in the context of the National Health Service, it's very much that the process that has delivered so much change in healthcare has been based on making sure that has been done with the workforce, and so that the workforce voice is heard as part of that process. Doesn't necessarily dominate everything, but it's process, the kind of partnership working that we see in the National Health Service. So I'm posing it as a question to any of the people who've made contributions so far. If you think that is a good principle, and unsurprisingly, I do think it's a good principle, what does that look like in social care? What are the kind of things that need to be introduced in social care in order to make those kind of things work and give the workforce a voice? So it's not just something that's done to them, but it's done with them.
Brilliant. Anybody else, before I ask someone to come back on that, anybody else like to make a point? So Nina's asking something in the chat. Do you want to ask it in person, as it were? You're welcome to.
Yes, sure, happy to. So my question is about joint training or career pathways, and I've asked it to Sir David because you mentioned it in your presentation. And I was thinking about the similarities between care workers and, for example, HCAs or healthcare support workers in the NHS. Given the similarities in their roles and sometimes their responsibilities, I wondered if you saw a case for a joint training pathway to cover both.
Great. And Phil, I don't know, did you want to ask a question, or are you going to?
Yes, I did. I wanted to ask a question. I'm intrigued by this dilemma that Sam has put to us about the centralised debate. And because the best delivery is going to happen when it's decentralised, devolved, and in partnership. And the white paper talks a lot about strong place-based partnerships between health and social care and so on. On the other hand, there are elements of centralisation, as we know in the white paper. And I wonder whether you square that circle, in my head anyway, and I'd like people's views, if you have national entitlements to social care that people can have, how those entitlements are met are not controlled by a nationalised, as it were, national top-down driven social care service, but by local people delivering those national entitlements to suit local areas. Because Birmingham's a lot different from Lincolnshire, is a lot different from Cornwall. And if you've got national entitlements that are locally delivered, does that square the circle? And could the white paper offer us that as an answer?
So that's three really interesting, diverse points. Who would like to come in? David, there was one specifically to you, actually. Would you like to kick off?
Yeah, so thanks. Joint training, joint career pathways. So yes, I think there needs to be career structures which join, but I think they need to be separate as well, actually. So I see a future. It's interesting that Matthew said one of the things that he and I have in common is we both started as social workers. So I think I see a career structure where people can work in care, then work in health, then go back into care, then go back into health. And I see a future with a much more permeable interface. I think what we want is agility and flexibility from the workforce. I think that was the point that was being made. And I think the skill is not about knowledge retention in the future. Do we train people to retain knowledge? But do we train people to solve problems? Because I think that's what the future workforce is going to be doing. So I don't believe what we should do is put health and care staff into a blender and flick it on and have a smoothie as a result of it. I think we need to see those distinct component parts. to a health and care workforce. But I'm with Matthew, and Matthew, I thought, gave a great answer about how in Cambridge, and I think this is true in other places, you'd be hard pressed to separate out what a good domiciliary care worker does and what a good healthcare assistant does in terms of the quality that's offered. Yet the difference in pay is about £1.50, and the difference in both their education and training is quite significant, let alone what it means to be supervised by a regulated professional as well. So my push, just to come back to Gavin, on registering care staff is not driven by a public protection, but it's driven by, you set a standard that people need to get to in education and training to get access to the register, and that's beginning to give you some assurance. So it's a slightly different approach than I think we've had to registering nurses and doctors, for instance, but just some thoughts. I'm not precious about those, but I'll leave it there, Caroline.
Brilliant. I wondered if Sam or indeed Matthew would like to come back in. I'm trying to spot if Victor's still with us. I think he might have had to leave for his other appointment, actually, but I can't see him at the moment. It was great to have him earlier. Matthew, a parting shot.
I mean, just two things. I think the difference, though, on Nina's question is the opportunity that therefore those workforce get. So I know two of my workforce in my trust down in our Luton area who started as healthcare assistants, and now they're trained nurses, and one of them's moving on to her master's, and it took her 4 and a bit years of real hard slog, and she did it employed. A healthcare assistant or a domiciliary worker would never have that opportunity unless they moved into the healthcare world. And it's not for everyone, I get that. But so we do need to work out what people might want to do, celebrating that not everybody wants to do that, but we don't give people the same opportunities potentially. I think the point that Philip raised, which is I grapple with this all the time about mandation frameworks, etc. My only issue, and let me use hospital discharge just as an example, my only worry is we need to, if we're going to allow local differences, which I'm a full supporter of, it's got to be in a boundary of unified data and evidence of what we're achieving. I look across the hospital discharge world and see the stark differences in the outcomes for people, whether they're going in prematurely into care homes, whether they stay in hospital longer than they need to, etc., all the things that we know. And I think I'm absolutely with you on saying it has to be localized, but it's got to be in, well, why aren't we understanding how well we're offering that opportunity for all those people and using that to drive improvement? That's a centralized approach, but it's a intelligent centralized approach for good outcomes, as opposed to you've got to do it this way because Morecambe Bay will be different to Ipswich, etc., etc.
Absolutely, great. And Sam, I think you've got the final word here.
Yeah, claim to fame. Just a bit for Gavin, actually, initially, which is it might be worth looking at the Northern Ireland regulator, Gavin, because they've registered social care workers and they have to do a 6-month certificate, but they've actually registered them on the basis that they are now going to work with social care staff and employers in looking at what they want to develop forward. So they're doing a joint piece of work. In relation to Philip's centralisation, decentralisation question, I think being an academic, that's probably an essay, that somewhere, I think, within all that. But what I would say around social care is the importance of setting national rights and entitlements, I think, would be a move forward around doing that. Because social care, the boundaries between formal and informal social care are quite fluid, and people move in between them all the time, between a formal service that's provided by an organisation and an informal service, which might be a family, a social network, it might be a community network. Because people move in and out of them all the time, that's where it's got to be localised. Because moving in and out of them all the time is also where your workforce is, because they tend to be from local communities. So I actually agree totally that actually a national set of rights and entitlements that are delivered on a local level would be the way to go.
Wow, what a fantastic conversation. I'm sorry there wasn't more time for questions or comments, and I apologise for that. But I think the inputs, this is such a rich conversation, and it feels like the beginnings of a incredibly important discussion. I'm